Hi guys, I'm Dr. Paul Vanek. I'm from Mentor, Ohio. I have a practice called Mentor Plastic Surgery. This is my time when I was chief of surgery. I divorced DeVritos since then and tried a couple months of semaglutide, and it's really revolutionized my game. Started going to yoga. I wish I sent myself a memo when I was 55 that I should start going to yoga when I was 35. So I sent myself a retrograde time capsule. So I advise any younger surgeons in the audience to start going to yoga and take care of yourself a little better, that when you hit your 50s and 60s, you don't show up looking like that in leadership and surgery. I participated in Renuvion since early on as an adopter, and I've been using VASER liposelection since early on when it's Bill Cimino and I met. But the question of can we do an abdominoplasty with two energies on the flap has been something that has not been dived on in scientific literature. So I'm going to present the largest series of two cohorts. One is a series of UAL lipoabdominoplasties and UAL VASER Renuvions on the same flaps. These patients have been studied across the board. I've got disclosures of different KOL positions of a couple companies. But the purpose is to see whether the abdominoplasty has different complication rates or historical complication rates that's seen in lipoabdominoplasty alone or abdominoplasty alone. So from a 77 consecutive cases with UAL, with or without the use of helium plasma, is the short version of this study, so that the complication rates between treatment groups were stratified. We essentially had two groups. The first group was, and I used different energies in zone 1, the areas that we know of the anatomic blood supply from the tram flap era. Zone 1 is right over the rectus. Zone 2 is lateral to the lateral rectus border laterally. So groups A and B had the same treatment with UAL over the 7-year period. And then the group A and B differences was group B had only Renuvion applied, and group A had VASER and Renuvion. Group B, VASER and Renuvion. So no Renuvion in group A, just keep that straight. Now, when we look at the demographics, these patients were stratified through the years. So essentially, we flipped a coin and the patients were enrolled or not enrolled. Did they get VASER? Did they get VASER Renuvion? It was their patient choice often. So they self-enrolled, and the demographics were essentially the same. The BMI was in the same normal range group. The Fitzpatrick skin types we even looked at. We looked at smoking and non-smoking. We looked at their relationships and other comorbidities, where essentially their anesthesia scores were the same in terms of anesthesia group risks. When we look at the stratification, here's the anatomic difference of zone 1. And I used a 2-groove 40V suction, so the energy was consistent. We did not suction with hollow cannula in this zone. And then the 3 to 5 groove, before Dr. Ruff and a couple other associates published that the seroma rate was increased with VASER over 80%, I was using 70 to 100 V in this region. And then I incorporated the fill ports, the access ports, to be below in the domain in which we would resect the abdominoplasty domain. So that's the surgical procedure in general. Now, when we break down the data, we looked at the infusion sites in each zone. That's, as you know, is clinical decision making based on their BMI and their fat characteristics. I did keep group A and B amplitude and groove types the same. Group A and B for zone 2, the lateral area infusion, those differences are essentially non-significant. They're just the differences between the BMI of the patients. And then the fat harvest in group A and group B were essentially the same based on, again, BMI when they're normalized. When we look at the helium plasma energies, the power I was using was around 80% throughout the flap, 79 plus or minus 6, 77 plus or minus 7, but they're non-significant between the groups. There's been discussion today, as you heard, in the amount of energy used per unit area. I think of that more as a unit area, but three-dimensional area. And so the energy I provided to the flaps were based upon the post-VASER reduction, which you see up to 80% reduction right in the operating room. When I look at the abdominoplasty procedure, it's a pretty standard abdominoplasty technique with wide undermining of the costal margin. You heard on the video 0 PDS. The group A and B skin resection margins, again, the differences are solely that attributable to the BMI of the patient at start. The average blood loss is 40 to 75 cc's. The drains are removed without significance whether the patient had Renuvion alone with VASER or VASER alone. No, non-significant. Adverse events are what we really were targeting, and the study groups of Group A of VASER lipoabdominoplasty had essentially the same historical literature comparison as just an abdominoplasty. So adding VASER did not increase morbidities in any of the adverse events we studied. And then the big question which I wanted to answer was adding VASER and Renuvion, were there differences in comorbidities or outcome adverse events? And there were no differences in the study group. The Group A VASER lipoabdominoplasty, 37 subjects, 40 subjects in the Group B with Renuvion VASER, non-significant differences. We looked at things like fat cysts, seroma. The seroma determination was not determined by ultrasound, and that's one of the criticisms of my own study. They were determined clinically, essentially with close follow-up in the first 6 weeks period. They had photographs, measurements, and they had BBL lasers at month 2, 3, 4 on their scars. But this is the worst adverse event in Group B, which is the UAL helium plasma patient. It's a high BMI patient who had some focal skin necrosis vision, but at 1 year post-op, which was 4 months after the scar vision on the left. Here's her before, and there's her after with a BMI of 27 at the inception at age 60, Sinlay. So essentially, the safety points for this, in terms of overall protocol assessment, no suctioning in the epigastrium. I keep the UAL energy low at 2 groove 40V. The helium Renuvion energy has been the same whether I'm treating the abdominal wall with or without the skin flap. And I can say now with years of doing this, I'm doing this in the arms, I'm doing this with open necks and closed necks, I'm doing this in thighs with or without thigh lifts, and buttocks at the same time as a buttock lift with or without fat grafting. The Renuvion in this case was studied exclusively in the abdominal wall flap. But the pros and cons, obviously the technology is prohibitive in energy. Now that we have a unique AON device that puts together the UAL device with the Renuvion device, that equipment cost is going to essentially be halved. The learning curve, with the help of Paul Ruff and some other really great minds, it took me about 4 cases to feel comfortable with the Renuvion technology. But the procedural time is about 10 to 20 minutes per zone, depending upon the BMI. I don't think the UAL adds net procedure time because it makes the suction time easier. I don't use power currently. These are articles that were included in the journal article that I was accepted at the Aesthetic Society. I presented this article in Vancouver in the fall. But these are benchmark cases of a series of adverse events for just abdominoplasty. And when you look at those numbers compared to one surgeon, the significant adverse events rate were similar between the 2 groups. There's no statistical difference in complications between the groups. The complication rates in both study arms were in keeping with other previously published studies. Adding helium plasma to the UAL abdominoplasty procedure, which is the headline, does not adversely impact the overall complication rate of the procedure in this series. Of course, it needs further large-scale randomized studies. That is the complication of having a single surgeon retrospective review. But when the protocol is advanced throughout the study period, I think that's a very favorable, powerful study. I'm so happy to be here. Reach out to me. We're going to be training people in the AON use, and you're welcome to call me up and ask what's going on with your patient. I welcome you to my practice.